Yep.
Yes.
So this is a young patient, 33 years old, had this liver lesion. It's a male. Also some additional findings.
Lymph node mets, or what are they? Let's see. Mesenteric.
Yeah, so basically he has a colon cancer with nodal mets and a large 10-centimeter liver metastasis. So colon cancer is becoming more and more prevalent in younger patients. There was actually a New York Times article about it last year, possibly due to low fiber. This patient actually had a lot of polyps in his colon, large family history. So they ended up doing a genetic workup. He didn't get a diagnosis of FAP, but he has like a hereditary ovarian slash colon cancer syndrome. That's kind of on the spectrum of Lynch syndrome. So there's all these different now subcategories of hereditary colon cancers they're finding. But anyway, so he had this solitary large liver metastasis. So they gave him chemotherapy, and for the treatment for colorectal liver mets to the liver is to try to remove all of the tumor in the liver. So they did a right hepatectomy. And you can see that his left lobe is actually already pretty big. So you need 30% of your liver remaining, but it looks like it's probably sufficient. So they did that. And then this past weekend, the patient's bilirubin, post-operatively, on day 1, his bilirubin was 5. So when you have a post-op increase in your bilirubin after hepatectomy, there's 3 main possibilities. One is that you have a biliary obstruction, like your bile duct was accidentally ligated, like if they accidentally clipped off the bile duct. 2 is that you have a bile leak, and that the bile is being resorbed by the peritoneum and then entering into the bloodstream and raising your serum bilirubin. The third actually is if you have massive hemoperitoneum or had a lot of blood transfusions during the surgery, because that can raise your bilirubin because you're cycling through the red blood cells. And then the fourth one would be if you had liver failure. And that means like if you had an insufficient liver remnant. So the one that is going to raise your direct bilirubin is when you have a biliary obstruction. The one that will raise your indirect bilirubin would be the other ones like hemoperitoneum or a bile leak. And if you have liver failure, usually you'll have both of them go up as well as a number of your LFTs. So in this case, we gave the patient Eovist. So this is our one patient of the day who got Eovist. And you can see that their left lobe is pretty big, but that the Eovist basically is seen within the bile ducts and then abruptly truncates here. And it never goes into the rest of the CBD, and it never makes its way into the duodenum. So we did this scan, and we started seeing the excretion of the Eovist at about 20 minutes. We saw more at 4. This is a 4-minute scan, and we never saw it going into the duodenum. So we actually then brought the patient back for an hour delay, and it still basically was here, and we never saw it excreting into an hour later. So now we're at an hour and 40 minutes. So we suspect here that there's some kind of biliary injury, either kinking of the bile duct or an obstruction. I did see another case similar to this, like after a cholecystectomy, where on the in and out of phase, you could see blooming right where it went away. And so we knew that actually there was like a clip that had been placed accidentally on the bile duct, with them thinking it was the cystic duct probably. So it's a pretty big complication. They're actually taking the patient back to the operating room today. So I don't have the final results yet. But another kind of strange, interesting thing is that we started seeing this tiny bit of contrast collecting above the kidney here. And so I do think that there's also a tiny little bile leak. It only got like slightly bigger than this at an hour. If this was fully leaking out, you should see a lot more Eovist collecting there by that time. So what we suspected was that there's probably some other tiny little biliary radical along the edge of the liver margin that's also is leaking a tiny bit.
It's interesting that it's not very dilated.
Yeah, that was actually what we kept talking about with the surgeon. He was like, "Why isn't it it's not very dilated. It's not dilating up." And actually, the liver remnant is growing, so it looks even bigger than the pre-op. So we think that it's not liver failure or insufficiency, but it's pretty ominous not being able to get any of the bile through.
Mm.
One thing, when you take out the right lobe of the liver, and basically the liver like can fall into this area, you can actually get kinking of the portal vein and kinking of the bile duct. So often they'll put like a big omental patch in that area. But because he had that colon cancer that they have to go resect later, they didn't want to manipulate his like omentum and mesentery. So that was another theory of like why it's become obstructed here. One other point for your residents is that once the bilirubin gets too high, EOVIS won't be excreted. So once the bilirubin is above like 10, 12, you may want to consider not giving EOVIS, because if it doesn't excrete, you don't know, is it because they're in liver, like, I mean, what it is. Basically, the liver is so jammed up with bilirubin that it's not going to excrete the EOVIS.
Good point.
Okay.